Welcome. I think currently we're in an exciting time for the treatment of aortic valve disease, and we have a great panel today to discuss what are the different options for patients who have aortic valve disease. To my left, we have Dr. Douglas Johnston, who's the surgical director of our aortic valve center. We have Dr. Samir Kapadia, who is the interventional cardiology director of our aortic valve center. And we have Dr. Leonardo Rodriguez, who's the imaging medical director of our aortic valve center. So why don't we go ahead and get started? I think we have a lot of surgical and interventional and imaging issues to discuss. I'm going to start, if you don't mind, with you, Doug. Patients, I think, have a lot of different options and ideas about usual sternotomy and mini incisions. What are the different options that you have, and what are the considerations that you make in choosing one type of incision for a given patient?
So, great question. I think that the most important thing that we want to think about is the safety of the operation. So we very much have a tailored approach here in terms of what incision we select for a patient, and it really depends on the goals and objectives of the patient in terms of their own health care. So we start with that, and we start with what problems we have to fix on the heart. So fortunately for a lot of patients with isolated valve disease, if we don't have to do a lot of different things for the heart, there are a number of small incision options. And most patients who just need an aortic valve or an aortic valve with ascending aortic repair, which is a lot of our patients, especially younger patients with bicuspid valves, we can do either a small incision between the ribs or a small sternotomy incision, typically under 3 inches, which improves the recovery and certainly makes patients happier than having a bigger incision. Now, people who need a lot of work done, what I tell them is, look, the difference in recovery is not that big. Most patients do really well with this kind of valve disease because they're going to feel so much better after surgery anyway. So the priority is let's fix what's wrong. Let's give the patient a safe, effective operation. And if we can do it with a small incision, which we can often, that's a great bonus.
Excellent. Now, Dr. Kapadia, as we discuss minimally invasive or less invasive options, transcatheter aortic valve replacement is a big option for a lot of patients, and there's been a lot of enthusiasm recently with the data that's come out to apply transcatheter AVR or TAVR to lower and lower risk groups. And we have found with some of the data that some of the early complications, things like stroke and paravalvular regurgitation, have also come down. So can you comment, in light of the recent data, how does that inform our practice here in Cleveland Clinic?
Very important because, as you know, last year we did close to 400 aortic valve replacement with transcatheter valves. And most of these patients who are referred to us are the patients still at high risk of surgery. However, if you look at the data in the recent time, the intermediate risk patients are the risk patients who have surgical risk of about 4% to 8%, meaning that the risk of dying from surgery is 4 to 8%. If you look at the recent data, there is no question that transcatheter aortic valve is equal, if not better, in terms of recovery to surgery in these intermediate risk patients. So what we have done is that we have a very important team with surgeons, cardiologists, and interventionalists, as you are part of, all of us are part of it. We try to analyze what is the risk and benefit to each patient for transcatheter versus surgical valves, and then we decide that surgical valve or transcatheter valve should be done. If you look at the stroke and paravalvular leak, they have come down tremendously in the recent data. So in the partner 3, in the core valve data, both of these data, the risk of stroke and paravalvular leak has reduced considerably. So with that in mind, I think the outcome of transcatheter valve is very similar to surgical valve. The durability is still something that we need to look at as time progresses, and that is where we are doing the low-risk trial patients to understand the durability of the valve. But currently, transcatheter valve is an outstanding option for patients who are intermediate risk patients for surgery.
Excellent. And Dr. Rodriguez, as a clinician, when you see a patient with aortic valve disease, and as a specialist in imaging, what are the considerations that you have when you're referring a patient for a treatment of the aortic valve disease?
That's a very important question because now the patients also have their own opinions. So we have to take into account the individual patients to see, as Dr. Johnston mentioned, the surgical risk and also other pathology that be associated. In that regard, the accurate diagnosis not only of the severity of the aortic valve disease, but also associated mitral or tricuspid valve disease, the size of the ascending aorta, all this is taken into consideration to go either the route of minimally invasive surgery or a percutaneous option for this particular patient. So we do a lot of workup before these procedures are done, and hopefully we have a complete understanding on what is the pathology this individual patient has.
Excellent. Now, one group of patients that we encounter rather frequently at a referral center such as ours are those patients who have previously had a surgical aortic valve replacement. And I think we have good options here at Cleveland Clinic, both for reoperation surgery or to place a transcatheter aortic valve within that failing surgical valve. So Doug, if you can comment from a surgical perspective, what are the considerations you make to say that a patient may or may not be a good candidate for a surgical reoperation?
So the first thing we look at really is the overall risk of the patient and whether there are other benefits to surgery besides just dealing with the failed valve. So if there are other things that need fixing, as Leonardo mentioned, if there's mitral regurgitation, tricuspid regurgitation, other aspects of the heart disease that may benefit from surgery. And the other side of it is this a young, healthy patient who has 20 or 30 years of healthy life ahead of them, where we don't know as much about the durability of transcatheter replacement. We have very good data on the surgical valves out to 20 plus years, and so in that setting we probably would lean more towards surgery. The other side is a patient who's very frail, who has other medical problems, and where surgery may be an undue burden on the patient. In that setting, transcatheter valve replacement is an excellent option. And then obviously there are a lot of patients who fall in the middle, and that's where having a team approach like we have here, where we can really get into the details with the patient and have the benefit of all this expertise and make a decision that's right for that particular patient.
Excellent. And Dr. Kapadia, from a catheter valve perspective, what are the considerations that you make and your thoughts?
So I think the most important, as you know, is the size of the valve. So if the size of the valve is such that if you can put a transcatheter valve inside and will have good hemodynamic response. So usually anything more than 21 millimeter surgical valve or 21 millimeter valve, there is not any concern that you will have a hemodynamic gradient or patient prosthesis mismatch once you put a transcatheter valve. On the other hand, if the valves are small, 19 or less than 21 millimeter valves, then we have to take that in consideration. The second thing is the coronary artery anatomy. That is very important. And finally, what exact type of valve we put inside of the valve-in-valve is also some consideration, whether a supraannular valve or valve inside of the valve are used. So there are several considerations that we take into account, and of course other anatomical things that need to be fixed, as Doug mentioned, ascending aorta, mitral valve, coronary artery disease. All of these things need to be considered before we decide. But very importantly, one thing to understand, valve-in-valve outcomes are almost better than native valve aortic valve replacement outcomes. So if you look at the TVT registry and if you look at the valve-in-valve outcomes from the partner registry, the patients with a native valve aortic valve replacement fare a little bit worse than valve-in-valve in the sense of mortality, stroke, paravalvular leak, and pacemaker requirement. So I think it is a very important treatment option for patients who require valve-in-valve.
And I should add that as valve-in-valve gets better and better, it's incumbent on us as surgeons to think every time we put a tissue valve in a patient that this may be the second option down the road. And so we're very careful in thinking about sizing, especially in younger patients, that we put in something that will be amenable to valve-in-valve. And anytime I talk with a younger patient now about surgery, about getting a bioprosthetic valve, that is one of the considerations down the road. We don't want to burn any bridges at the first operation, either for open surgery in the future or for valve-in-valve.
Excellent, yeah.
I think it's an important point, and something that all of you have brought up is the idea of the younger patient. So when you're getting a younger patient, what are your thoughts, Dr. Kapadia? Can you comment on how does age factor into your decision-making for transcatheter aortic valve replacement versus surgical?
So currently, we are not using transcatheter valve in very young, healthy patients who are surgical candidates outside of the clinical trial. So if the surgical risk is less than 2% by the STS score or 3% by the STS score, and remember in Cleveland Clinic, the risk of operation is even less than what is predicted by the STS score, then we refer them for surgery. However, we do have an option for having a low-risk trial where we randomize patient to surgery versus transcatheter valve. What is the most important consideration? Why we are randomizing? The reason for randomization is that we do not know the durability of the valve and the procedural risks in young patient, because the need for pacemaker, need for paravalvular leak, need for, risk of stroke is actually not higher by all the studies. But at least the pacemaker rate, there is some question whether the pacemaker will be higher with the transcatheter valve or not. And the paravalvular leak, even though mild, if it is higher than surgical patients, long term, it may have a deleterious effect. So these are the reasons why we are investigating this. But it is an outstanding option. If they do not have a bicuspid valve, if they have a bicuspid valve, still we do not have enough information to use transcatheter valve. So we are not using transcatheter valve even in the study. There are some registries. But mostly for the patient who are younger patients, we do have an option for PARTNER 3 randomized trial.
So I think the bottom line is that we have excellent options, both by way of surgery and by way of transcatheter options. I think the most important is that we all see patients as a group, as a team that involves clinical cardiologists, imaging specialists, interventional cardiologists, cardiac surgeons, and nurses, all to get the best answer for a given patient.
One question that I had, maybe you can answer or maybe Leonardo can answer, is when a patient is referred to us for aortic stenosis, and if they do not have a lot of symptoms, but they have severe aortic stenosis, at what point do we decide that they need corrective therapy? Is it moving, the needle is moving towards more asymptomatic patients, or we are still able to, we are still waiting for symptoms, or what are the ways that you analyze the patients?
So first of all, we need to be sure that the patient is truly asymptomatic. So some patients that say so, if you push them a little bit further, they actually develop significant symptoms. So we use very often a stress test on these patients to try to elicit symptoms, also electrocardiographic changes. So this is a very important part of our workup. Secondly, it's true, as the mortality is lower, we tend to do less and less symptomatic patients. There are some guidelines in that regard. For instance, valves that are very severe, when the valve is really the size of the aortic orifice is very tiny. Valves that are severely calcified, they may be considered for surgery even if they don't have any symptoms. I think, as I was said before, it depends on the risk profile. The lower the risk of the patient, then obviously we try to do surgery earlier too.
So I think it's a very exciting time for us to go to the low-risk patient earlier in the treatment of aortic stenosis and have all the options on the table in a center where you have best transcatheter valve and best surgical group. So it is it's an exciting time and a pleasure to work here and see the evolution of treatment.
I think it's important to remember that there are still a lot of patients who are undertreated for this disease. And while we have these amazing therapies available, we still see patients who are very advanced with their disease, and we still see patients who die of their aortic stenosis without treatment. And it's not very well known that aortic stenosis has a survival, once symptomatic, that's worse than many cancers. And yet we still see patients who are treated late. So I think one of our jobs in doing things like this is to get the message out of how advanced the therapy for this disease is, how well patients do, and hopefully that will get people in for evaluation earlier. Some of those patients will get watched, some will get surgery, some will get TAVR, but the best we can do is get people in the door, get them echoes, get them to see our great cardiology team, and start the process.
I think it's very important. I think those patients that have significant aortic stenosis and we decide not to intervene, this patient needs to be watched very closely. We see this patient a couple of times a year and with repeated studies and always asking the same question: how are you doing? Have you developed any new symptoms? And if that is the case, we promptly refer them either to interventional team or the surgical team for quick treatment.
Wonderful. Well, Dr. Rodriguez, Dr. Kapadia, Dr. Johnson, thank you all for an excellent discussion, and I hope it was helpful.